Well, I too am very honored to be here to talk with you. I think there's a very exciting field that we're faced with, and we're getting many, many new technologies that help us understand both the biology of disease as well as how to improve antibiotic treatment. And you've all heard about the issues with antibiotic resistance, and I'm mainly going to focus on the use of new diagnostics for either surveillance or treatment. Next, please. This is my concept of infection control, if you will. I'm also one of the epidemiologists at our healthcare system. And there's about 10 components to infection control that are important for reducing antibiotic resistance, and the laboratory is heavily involved in 5 of them. I'm only going to talk about 2, and one is screening and isolation, represented by the Great Wall up there, with the idea is trying to build barriers between yourself or your patients and keep out bad things so that the patients you're taking care of don't acquire new kinds of, in the infectious disease standpoint, antibiotic-resistant infections. And the other is rapid diagnostics, and Stonehenge is there because it still is a little magical how some of this works. It's pretty amazing when you start working in the field, so that instead of having to grow bacteria like we used to, we just grow their DNA, and we can change the obtaining of results from 2, 3, or 4 days to about 2 hours. So this does offer great potential for the rest of this decade on changing how we use antibiotics, because if we know what our patients' organisms, their infections are susceptible to, we can tailor that therapy to exactly what they have and not have to use very broad spectrum antibiotics all of the time. Next, please. So there are several FDA-cleared tests for surveillance. There are 6 for methicillin-resistant Staph aureus, or MRSA, 3 that will detect both methicillin-resistant and methicillin-susceptible Staph aureus, and then 1 for vancomycin-resistant enterococci. Next, please. What I think is important is on this slide, and we've had a large program on MRSA control going since the summer of 2005, so we're approaching our decade point. And what you can see from this slide is that most of the patients that are colonized with MRSA are over 60 years old. So this is almost a risk factor for other disease, just like diabetes is a risk factor for losing your eyesight or losing your kidneys. Being older and being colonized with MRSA increases the risk of infection. If you have MRSA colonization, your risk of infection is more than 10 times higher than if you don't. So you can see this is a large issue for CMS beneficiaries, and I think this is important for all of you making policy to understand. Next, please. So what is on this slide is what the benefits are that you can accrue from a comprehensive MRSA program that works. We did a very, very stringent and very broad-looking way at cost for the healthcare system. It costs our healthcare system about $24,000 for each patient with MRSA that develops, and during the 8 years of the program, we've prevented 813 of these infections, and what's important is that the direct benefit from this expense reduction is over $16 million so far, $8 million per year. That's the excess medical cost, the $2 million excess medical cost per year to the healthcare system. About half of this accrues to CMS and half of it accrues to our hospital. Currently, in most of the regions, CMS is not reimbursing hospitals for doing this, but it's as an incentive, this would be a way of actually reducing the overall healthcare burden in a dramatic way. We've also avoided 144 deaths based on the CDC data that invasive infections from MRSA have a 20% mortality. Next, please. And this is our overall data. We first looked at our intensive care units, which is the second bar from the left compared to the baseline, which was the far left bar, and we did not see an improvement with MRSA infections when we just looked at the intensive care units. When we expanded the program to the whole hospital, so we're doing this for all of our patients, we're able to reduce MRSA infections by 70%, and you can see In 2010, we had 2 bloodstream infections in 4 hospitals during an entire year from MRSA. So very, very dramatic reduction in this particular infection. Next, please. Once you understand your population and you have people that are good with numbers, good with statistics, you can actually predict who you need to test. So you don't need to test everyone. So you can actually reduce the amount of testing that you're doing. And a colleague of mine, Ari Robacek, another physician epidemiologist at our hospital, derived a prediction rule based on 23,000 patients and then proved that it actually worked on another 26,000 patients in our system. And the next slide shows us what the benefit was. So next, please. So this is a prediction rule. The curve is the computer-generated percentage of patients that need to be tested to achieve a certain capture of the number of MRSA patients that you want to be able to detect for whatever intervention you're using. So you can see from this, if we test 50% of our patients, we can capture 90% of the likely MRSA disease, and we implemented this at our hospital in January of last year. So we've been doing this prediction rule from that. And one thing that's very interesting about preventable infectious diseases is as you start to prevent the infection, your expense goes down because the problem goes away. So it's not like breast cancer screening that we can't stop, we have to keep doing. It's not like prostate cancer screening that we have to keep doing. Infectious disease screening will go away, just like smallpox went away, will go away as we control the disease. Next, please. So this is the article I think that was brought up a little bit ago, looking at what is the difference between targeted surveillance where you're screening and then isolating versus just giving everybody a body wash and decolonizing their nares. And we looked at our last 38 months in our intensive care unit program, and I put the comparisons up here. So the first comparison is looking at the patient days, and you can see that we had there were 101,000 patient days in the published study. If we look at our NS as the North Shore results, in our last 38 months, that's 55,000 patients, so fairly comparable number of people enrolled. The rate of MRSA clinical isolates. What this means is you look at the clinical specimens that come to the laboratory and only count those, assuming the doctor sent them to the laboratory because they thought the patient had infection. And you can see in the best intervention in the published study where everybody was getting body washes with chlorhexidine, Petersen decolonization, the rate of clinical MRSA isolates was 2.1 per 1,000 patient days. Ours at the end of our intervention is 0.3 per 1,000 patient days, so 7-fold better than what was being done with the chlorhexidine washing. If you look at all-cause bacteremia, that's bloodstream infection from any organism, what was published in this was 3.6 per 1,000 patient days. Our data is 1 per 1,000 patient days. And if you look at the MRSA bacteremia, what they published was 0.6 per 1,000 patient days. Ours is 0.018 per 1,000 patient days. We have 5 ICUs in 4 hospitals. In the last 38 months, we've had 1 bloodstream infection due to MRSA. So I think this shows that if you have a comprehensive infection control program that actually targets each individual problem in a unique way, it's a potential to very, very much lower the disease that you're experienced and exposed to. Our North Shore cost is $27 to $37 per patient, and that includes the multidrug-resistant gram-negative. So we have our own in-house developed test for carbapenem-resistant Enterobacteriaceae, or CRE, and we screen in our ICUs for that. And the cost of the reported cleaning or skin cleansing and nasal decolonization was $40. So I think appropriate use of molecular diagnostic tests can be very effective in the hospital system. So there are prototype of these multi-drug-resistant tests that are in commercial development. The issue has been that when you start looking at multiple targets, multiple things to diagnose on a single laboratory assay, the FDA often requires 100 positive results for each of those targets, and that is virtually impossible to achieve. So I think the FDA probably does need to look at some new ways of approving these very complex infectious disease-related tests so that there is some post-marketing surveillance to prove that they're actually working. But if we wait for them to go through the normal process, it will be very, very difficult for them to come to market. Next, please. Last thing I want to look at is what happens when you have an infection with a multidrug-resistant organism. The question was raised, why are we having more and more issues with this as time goes on? If you look at the right-hand slide, that's mortality per day as it takes you longer and longer to get on the right antibiotics from a serious infection. And as we see more drug resistance, we see more broad-spectrum therapy used right at the beginning to avoid the problem of not giving our patients the right antibiotic. And so this actually then, this is a self-perpetuating problem, driving more resistance to the new broad-spectrum agents. And the best way to really deal with this in a way that makes physicians like Cynthia and myself feel that we're comfortably doing the right thing is to have rapid diagnostic tests that actually tell us what the patients have or don't have right at the beginning. And my last slide is the next one. This is a paper looking at detection of either methicillin susceptible or methicillin resistant bloodstream infections out of blood culture bottles as soon as they go positive. So instead of having to wait perhaps 1 or 2 days after we know that there's a positive blood culture to find out what the antibiotics are that we need for treatment, we can do this in 1 or 2 hours. And you can see there was quite a significant, almost unbelievable, but very significant a reduction in length of stay, 6.2 days shorter, and the hospital costs were $21,000 less per patient when they establish, as I've looked at the data, it looks very robust into how they did this, so very, very dramatic response. And my last slide is next, please. So I think for the impact of novel testing for control of critical pathogens, the role of the clinical laboratory working with infection control remains essential. And these rapid technologies really do enable efficient detection of critical problems. The role of rapid diagnostics in microbiology, partnering with infection control, will revolutionize the prevention and treatment of these challenging healthcare associated infections, and certainly have the potential to reduce antibiotic resistance during this decade. Next, please. Thank you very much. So the question was, is there a concern over Petersen resistance if you're decolonizing everyone? At last week's general meeting of the American Society for Microbiology, we reported our data on this starting in 2005 and then up until 2013. And we only decolonize about 4.5% of our patients. Our Petersen resistance has gone from 3% to 11%. So clearly this will be a major issue if we start to decolonize everyone. And the main benefit of both this paper in the New England Journal and another one in February in the New England Journal where they just used chlorhexidine was that the disease that was prevented were coagulase negative staphylococcus. So really you didn't reduce Staph aureus, MRSA, or any of the gram-negative. It was all coagulase negative staphylococcus. Yeah, please.
So in the very last slide, you kind of hedged your bet and said this has the potential to do, et cetera, et cetera. So from the standpoint of prioritizing our R&D in the future, which are the holes that most concern you in the protocols or capabilities that bring the outside forward?
Excellent question. I think one of the issues is that if you apply whatever technology, whatever intervention to too small a population within the hospital, you won't see a benefit because people move back and forth very quickly. If the last New England Journal paper, the length of stay for half of the patients was less than 3 days, so they're going out to the ward, so people are going back and forth. So I don't think you can really just focus on the intensive care units. One of the other holes in research and development funding is the use of information technology, just like we can do a prediction rule for who we need to test. If you have a large database, you can do very good prediction rules on who needs what antibiotics based on your last 1,000 patients that were the same age and have the same presentation. So that can be very helpful as well for us. And the third thing I think is that if we want to get widespread buy-in to the use of new technologies, there's going to have to be a partnership between the hospitals and the government in paying for them. I think both will have a good return on investment, but when these are perceived as being expensive, you'll get one hospital here doing it and one hospital there doing it. And these antibiotic resistance issue is a population basis. There was a nice study out of Brooklyn 15 years ago showing that if you were a hospital that wanted to avoid an antibiotic-resistant problem with gram-negative bacteria, you had to be 100 miles away from a hospital that had the problem. So we really have to deal with these, I think, more on regional groups rather than individual hospitals.